Big button, now you can hear me. Lovely. Ladies and gentlemen, you're very welcome here tonight to a new venture on the part of the European Parliament in Dublin, the European Parliament Spring Talks. Our ambition with this first set of talks is to look at a series of problems which Ireland continues to encounter and to look for solutions to other EU countries in the hope that we can find ways to deal with these issues without reinventing the wheel. There are a fair amount of misshapen wheels trundling around this country that might have been more circular and useful had we looked at comparative societies and emulated their wheels. So the three subjects we're going to engage with over the next month are tonight, health policy and implementation, focusing on things like long waits for diagnostic tests, the crisis in our GP service, recruitment and retention of staff, the long wait for digitised records, and the snail-like progress towards sláinte care, our proposed attempt to end an inequitable two-tier system. To discuss these issues, we have Irish expert Sara Burke from Trinity College and European expert Dimitra Panteli, who has an encyclopedic grasp of health systems in Europe. Alex White will moderate and I will introduce him shortly. He will introduce our two speakers at more length. On the 20th of March, we'll discuss social housing, focusing on the emergency we now have in housing, which is now being brought to the attention of the Oval Office in the White House. As you may have seen yesterday, that Mr. Trump said it was a good thing because we're doing so well, which goes to demonstrate his profound ignorance about that and many other things. Anyway, we have a housing crisis and we've had one for quite a while. We need new housing for our citizens and newcomers, and public housing has a crucial role to play in solving that problem. We urgently need to look at the class dimension to social housing and our desperate inherited desire to own our own homes, which is a mysterious and strange subject that can do with a bit of excavation. To discuss that, we'll have Irish expert Lorcan Sara of Technological University Dublin, European expert Michaela Cower, coordinator of the EU Urban Agenda Housing Partnership, who's deeply involved in the social housing system in Vienna, where half the population willingly and delightedly live in social housing and pay tiny rents compared to the money that is charged in this little country of ours. Dáithí Downey of Dublin City Council will moderate that. And on the 27th of March, we'll discuss children's rights, looking at the lamentable extent of child poverty and homelessness in Ireland and the consistent failure to provide vulnerable children with mental health issues with the care and treatment that they need. Ireland signed up to the UN Convention on the Rights of the Child in 1992, but still has a long way to go to implement its provisions. Our Irish expert will be Ireland's Ombudsman for Children, Niall Muldoon, and our honorary European expert will be former Scottish Commissioner for Children, Bruce Adamson. As you all know, Scotland voted by 62% to remain in the European Union, so we're allowing them to enter briefly on the night of the 27th of March. Nolene Blackwell, who all of you will have heard of, currently at the Children's Alliance, formerly of FLAC, and the Rape Crisis Centre, will moderate that discussion. There are many other areas which could profitably be explored for European models which we might emulate, and if this talk series becomes an annual event, we will focus on them all. Now, I was going to talk a bit about an example from here that I was involved in about how we can do that sort of thing, but I don't want to take up time from our wonderful experts. So basically what we're trying to prove, I suppose, in this series of talks is that it's always possible to find someone who has done your thing before you have. It's rarely the first time that things have happened. If it is, that's great and wonderful, but it's very unusual. And if the people who have done it are state agencies, they may be happy to help with their experience and expertise for reasons other than trying to profit from you. So two lessons to be learned there that we can do that. Why not take advantage of the Europe-wide reservoir of knowledge that awaits us out there to try to solve problems with which we struggle? We'll be diving into that reservoir during the month of March as we explore some of the issues I have mentioned earlier. And now to our moderator for this evening. Alex White was president of Trinity College Students' Union in the 1970s when I got to know him first, and was a very radical person indeed. Between 1984 and 1994, he was a current affairs producer with RTE, working on a wide range of radio programmes when radio really mattered, folks, when you turned on the radio every morning and everyone listened to the Gay Byrne Show, for which he was a producer for 4 years before he left to take up practice as a barrister. He is indeed an eminent barrister with expertise in employment law, and he's been a senior counsel since 2010. Alex is a former Labour TD for Dublin South and former Minister for Communications, Energy and Natural Resources from 2014 to 2016. Before taking up that post, he served as Minister for State at the Department of Health with responsibility for primary care from 2012 to 2014. While in the Department of Health, he introduced free primary care for children under the age of 6, a landmark event in an incremental approach to equitable healthcare, and something that did, I think, shift the dial in terms of our willingness to extend healthcare to all of our citizens. While Minister for Communications, he gave us the Air Code, then somewhat scorned, now acknowledged to be one of the most useful set of letters and numbers of the many we have to remember. We finally know exactly where we live, and there's no problem getting an ambulance to come there should we have any trouble. He's been a leading practitioner in employment and labour law since 1994, and he's now Director General of the Institute of International and European Affairs. Alex, I hand over to you.
Katrina, thank you very much. And if I'd known that you were going to that you were going to say all that, I'd have prepared some notes to speak about you, my dear. But what I will say is to congratulate Katrina Crowe on organising this series of talks and events. As she has said, it behoves us to understand and, in some cases, analyse how others have done in relation to compelling social and problems, social, economic and other problems that the country faces. And probably in the area of health, I would have thought in the area of health, no less than in any other areas of public endeavour. Katrina mentioned that I was in the Department of Health for 2 years. And I remember on my first day in there being told by Eamon Gilmore, who was tasked to do 3 things. He said, I want you to legislate for the X case, I want you to bring forward the public health alcohol bill, and I want you to get started on free GP care. So we managed to do all 3 of those things, actually, not finish, finish the X case, which went on, of course, to pave the way for repeal of the 8th Amendment. But on public health alcohol, we progressed that initiative, and I know one of the themes that our speakers are going to address is prevention and health promotion. And it seems to me that alcohol and the public health dimension of alcohol policy is a critical aspect of that. And in relation to free GP care, Katrina kindly mentioned that my role in that. That was not easy. That was quite there were many obstacles, many difficulties that we faced. We managed to get it over the line, as they say, only to age 6. And that's a big disappointment for me still. It's age 8 now, I know. Sláinte care has come in the meantime, and it has progressed. But, wouldn't it have been great if we said, right, we'll do it to age 6 or age 8, whatever it would be, and we will never take it from anybody thereafter. That would be a way of moving it forward. We say each year when a child becomes 7, 8, 9, 10, they don't lose it. So where are we now? 2025, so it's 11 years on. It would be to age 17 or 18 now. And in fact, that age cohort, Sara will correct me if I'm wrong, that age cohort between sort of 8 or 9 and 18 isn't the most expensive cohort of the population to fund free GP care for. So that's where we'd be now if we just kept it. And it was always meant to be a stage, by the way. It was never meant to be something that would be cut off in any kind of arbitrary way, but we had to start somewhere. But in any event, that's something that I was involved in. The Lancet last week begins with the following sentence, or one article or editorial in the Lancet, and I quote, "Despite being one of the richest countries in Europe, Ireland is the only European country without universal coverage of primary health care," unquote. That was the case 15 years ago. It's been the case for many a long time, and sadly it remains the case. And I'm sure it'll be one of the things that our speakers will focus on in the course of their presentations. 2 eminent, experienced speakers of the highest calibre. We couldn't have 2 better speakers, it seems to me, in terms of our reflection on this subject. Sara Burke is Director for Health Policy and Management at the School of Medicine in Trinity. Dimitra Panteli is Programme Manager of the European Observatory on Health Systems and Policies. And I'll say more about Dimitra when I come to her response, because the way this will happen is Sara will make a presentation. and Dimitra will respond, which I think we're all very much looking forward to. Say a little bit more about Sara Burke. She didn't want me to, but I will anyway. Professor Sara Burke is an associate professor and the director, as I said, of the Centre for Health Policy and Management, which is part of the Public Health and Primary Care discipline in the School of Medicine in Trinity. She's also a co-director of the National SPHERE PhD programme, and she's principal investigator of a research project entitled Producing a Health in Transition, Health System Review for Ireland as part of the European Observatory on Health Systems and Policies, HIT series. There's much more that we could say about Sara. I won't take up too much more time doing that. You'll forgive me for that. I'll hand over to Sara Burke. I look forward very much to her presentation, and I give you the floor now, Sara.
Great. Thank you, Alex. Okay, they wanted me to sit at the high stool, but I'm slightly allergic to high stools and I can't stay still, so I'm going to stand instead. So good evening, everybody, and thanks to Katrina and the team here for inviting us to this event this evening. With the topic health policy and implementation in Ireland, and I've been given 20 minutes to do that. Okay, so I am timing myself here. Oh no, I didn't set it. When Katrina rang me up, it was probably about this time last year, Katrina, because they were going to be in the autumn or something, and I just got this stream of consciousness from Katrina Crowe, and anyone who knows her will know you can't really say no to Katrina Crowe. There's a poem in that. And she was like, how much are we spending? Why isn't the system better? Are we really a basket case? Trolleys in emergency departments, wait lists into hospitals. We do terrible things to people in the healthcare system, and then they have to go to the High Court, and we don't even admit it till at the steps of the High Court. Our workforce are buggered and don't want to be here anymore. And it was just this total stream of consciousness. And she was like, "Can you come and talk to us about that for 20 minutes?" So I'm not going to do that. But what I'm going to do is take a brief look at the crises, or the black spots, or the problems within the system. And then I'm going to look at some bigger, broader, very high-level macro data to look at sort of the good and the bad of the Irish health system. And then I'm going to talk a bit about Sláinte Care and the policy direction. And sorry, I meant to say the slide. So everything I say here this evening is my thoughts and demons for about the last 6 weeks. I've been trying to process what I would take. But obviously there's a team of people who work in the Centre for Health Policy and Management, and in particular Veronica Segerström, who's a researcher who I work with at the moment, who helped me with some of my data slides. So thanks to Veronica. And particularly just want to call out Lishna McAneil, Una McAuliffe and Paul Levy, who are 3 PhD students I currently have the privilege to supervise, who always challenge and help me with my thinking. But in the last month, I've had the privilege of listening to the 4 people in the images there on the slides. And the first one is Professor Andrew Murphy, who's Professor of General Practice in the University of Galway. And he won the HRB Impact Award a month ago. And I think Sarah Barry is the only person in the room who was there for just this very humble speech about being a general practitioner in rural Ireland. And he's one of the sort of unique academic GPs. We have some really fantastic academic GPs across Irish universities, and talking a really heartening, hopeful story about how GP care and primary care has improved in rural Ireland, and just the quality of life that he can bring to people in rural Ireland now. And it was a really positive story. And so I was influenced by that. And then the keynote address at that event was the other man in the picture, Kumanan Rasanathan, who's the head of health policy and systems in the WHO in Geneva. And I stole my subtitle from him, which was The Long View. And he was talking about global health. And for any of you, most of you, I'm sure if you're here, are tuned in to what's happening across the world, and really just this global health crisis we're in, particularly related to the cutting of US aid to development countries. And so there's rarely been such a crisis in the global health world, and largely in low and middle income countries. But he still gave quite an optimistic take, going, if you take the long view, global health is much better now than it was 50 years ago. So that's what triggered my long view. And then Lucy Gilson and Roisin Shortall spoke at the SPHERE PhD conference a week ago. And I think it was Lucy who opened talking about how it's more important than ever to have spaces like this. So thank you, Katrina, for the opportunity, because of the contested world we live in, what she called BANI, I hadn't heard it before, the brittle, anxious, non-linear, incomprehensible state of the world we're in. And that is all the more reason to have discussions like this about the importance of health systems and policies and what they do to achieve our collective health goals, and then the importance of the role of the health system in helping achieve those health goals. So I'm going to briefly touch on and then park the basket case analogy and the crisis. And you don't have to Google too far to find a headline on a problem or a crisis within the Irish health system, whether it's about how much we've overspent on the National Children's Hospital, our continuous overspending on health every year up to last year, needing a bailout in the health budget, a lot on the crisis of staffing, in recruitment and retention. Interestingly, if you Google it, it's all the doctors that come up, not the other healthcare personnel who are just as important, if not more so. And then a lot around trolleys, difficulties getting into hospitals, but also other crises such as, most of you in the room will be aware of the crisis in child and adolescent mental health services in the southwest of Ireland over the last few years, but in general across the mental health services. It's very hard to get into the mental health services unless you're acutely unwell. And then when you do get in, there's an overdependence on medicalisation and not enough access to talk therapies. So anything else I say is in the context of complete acknowledgement and awareness of each and every one of these crises. And it's not for a moment that I'm saying they don't exist. I'm saying they do. But what I'm hoping to try and do is take you back into that bigger picture. So if we look at the sort of demographic data, it's a good story in Ireland. We've a growing, more diverse, youthful, healthy population, but also one that's gone through extreme growth. So we've gone in 25 years. It was quite hard to get the data for 50 years, so most of my data is 25 years, because it's easy enough to go back to 2000. It's harder to go back before that. So we've gone from 3.8 million to 5.4 million. We're living longer than ever before. I'll talk a bit, I have a few graphs on life expectancy. And we're doing comparatively well. Like, obviously, I could have filled the 20 minutes with a bad news story. But actually, I think if you look in the round, it's quite a positive story. So I'll show you some of those indicators. And also just to flag that a lot of this that we're talking about, while the health system is important, a lot of the increases in life expectancy are directly related to increases in living standards and better quality housing and education, access to clean air, rather than specifically the health system. So just to keep that in mind, it's not just about healthcare policy, it's about the broader public policies that make a difference. So if we take life expectancy, which is obviously used as a measurement of success of the health of a nation, and these are the EU 27 from the report Dimi has on her desk, which I'll let Dimi talk to you about. So we're 2 years higher than the European average in terms of our life expectancy. So we're doing pretty well in terms of our life expectancy. And then the bar chart on the right is what happened during COVID. So all countries experienced a drop, often for the first in a long time, in life expectancy because of COVID. But if you look at our life expectancy during and since COVID, we did have a drop, but our drop was less than most other European countries, and our recovery has been quicker. And then if you look at our smoking figures, and I couldn't find somewhere which had the 2002 to now, but our smoking rates in 2000 was 36% of the population. So more than 1 in 3 of the population smoked every day, or whatever the figure is. Now it's 17 or 18%, depending on which data you use. So that's a really significant, and that's contributing to some of those extra years of life. And the government set a target of getting it, a very ambitious target, it was James Riley, of getting it down to 5% by 2025. So obviously we're not going to achieve that. We got down to 17, 18, we've sat on that, and that's largely driven by inequalities, and we'll come back to that if I have time. But really good progress in relation to smoking. And then in relation to, and this is the data that used to be called amenable mortality, terrible name, and now to get rid of the terrible name, they call it preventable and treatable mortality, like that's any better. And basically, it's a measurement of the health of a nation, of what prevention and the health system can intervene on. And in this slide, the further you are to the right, the better you're doing, rather than the other way around, which it usually is. And we've gone from being right at the other end. We were really, really bad on amenable mortality 25 years ago. And we're now much better than the EU average. And this is absolutely recognised internationally as an indicator of health system impact on people's health, particularly that treatable mortality. And we're actually doing better on the treatable mortality than on the preventable mortality. And then this is the one that you hear the politicians use all the time. And I'm sure you used it, Alex, when you were the minister. But, everyone says, in every European survey, Irish people say they're the healthiest in Europe. And in every European survey, we do say we're the healthiest in Europe, but we're not the healthiest in Europe. Right? And there's another, we can have that discussion if we have time. Okay, so that's largely a good news story in relation to those sort of macro indicators. And yet, it's very important to say that beneath those figures, there are real inequalities between people from lower socioeconomic groups and higher socioeconomic groups. Even if you take the crude life expectancy, men and women from lower socioeconomic groups live 5 or 6 on average less than their higher income counterparts. And then we have particular groups that experience really acute inequalities, such as the traveller community, who live on average 15 years less than the population as a whole. And the figure for suicides amongst travellers is really extraordinary, with 11% of all deaths of the traveller community being suicide, and that's 6 times the national rate. So just particular inequalities that really have not been solved. In fact, the inequalities have got slightly better, but they still remain extremely, problematic. And then obviously there's also these difficulties with the health system whether we're talking about emergency departments, the waiting times to access care in the community or in the public hospitals, or the overall fragmentation of the system. And anyone who's had to navigate the system for themselves or a loved one, and I've had to do it recently for my own mum, and it's really hard. It's really hard to navigate, even for someone with the knowledge and education, the wherewithal of the health system that I have. It's still really hard to navigate your way through that system. And there are particular areas that we're failing in. I've mentioned some of them already: mental health, disability, particularly services for children with disability, neuro-rehabilitation. It's an area Sara, Barry and I did some work in a couple of years ago, and it's just the shocking absence of supports in the community for people who need neuro-rehabilitation. And we're trying to do the primary prevention, but we're not doing half enough of it, or, we're doing a fraction of what we do, but also that secondary prevention. So once you have some condition, just how we keep people healthy, we're not very good at that. And we have been very poor in the digital space. And there's recent EU ranking of countries of how we're performing in digital health, and Ireland comes out at the bottom at the moment. So actually, for anyone interested in this, there's a fantastic HSE podcast interview with Damien McCallion, who's responsible for that in the HSE, and it would actually cheer you up about all the things that are happening. It's slow, but they're happening in the HSE on the digital front. And these are just the figures Veronica put together, which been tracking over time for about 15 years now. So this is when you go to see your specialist GP, the amount of time, how long you're waiting before that first specialist appointment. And so these are hundreds of thousands of people. The highest figure there is 650,000. And what you see in the recent past is actually some progress in bringing it down, despite high numbers presenting. Obviously, there was a COVID factor, but some, nobody should wait more than 3 months. What you're seeing here is people waiting over 6, 9, 12, 15 months, but some impact. And that's largely what James Riley did in 2013. That's throwing the kitchen sink at it. That's contracting out to private providers and making sure that appointment happened. What's less successful And this is a real issue. So about 1 in 70 of these people who see a specialist will then go on to need treatment. And these lists are going in the wrong direction, but also the numbers are all going in the wrong direction. So even though the HSE are diagnosing and treating more people, the demand is greater than the treatment level. And so these figures are continuing to go up. And from talking to people about what's going on here, I think the political attention is on that first outpatient appointment rather than actually getting the system to meet this demand, although it's very difficult to meet. Okay, I need to hurry up. So, I'd loads of other slides I got rid of on workforce and financing, whatever, because I wasn't going to have time to go into them. But we do have a much bigger workforce. We have many more people working in the public health system, but across the health system, we have a more diverse workforce, and we've many more services than we had 10 or 15 years ago. So there's a whole range of new women's health services that have been brought in, particularly under Stephen Donnelly, really championed women's health. A lot around chronic disease management, championed by the HSE under the Enhanced Community Care Programme. Big progress in palliative care, inclusion health, and integrated care, albeit in pockets. The integrated care tends to happen if you're in a particular population or a particular disease group, rather than as a system as a whole. And we have a plan, and the plan is Sláinte Care. And Sláinte Care was devised by cross-party political consensus in 2016, 2017, and then adopted by government in 2018. And this is now the third government adopting the Sláinte Care plan. And as preparation for today, I read the minister's briefing, and really it's stitched throughout it is the implementation. I read both the HSE service plan and the briefing for the minister, and really underpinning both those plans is the implementation of Sláinte Care. And with that, this shift to the left to provide more care, the lowest level of complexity at home and in the community. We're beginning to get a focus on patient outcomes, rather than just how many numbers go through a service, but actually how does the patient feel? Is the person better? Do they have a better quality of life? And that's really positive. And I think we did well during COVID. I know there were certain areas, there was absolutely areas we did wrong or we didn't do so well. But overall, as a country, I think we managed, and the HSE and the health system and public policy and the politicians did very well with COVID. And we have made progress on access and affordability. And part of that progress is the free GP care, although I'd agree with Alex, it's far too little and too slow. And it's not free primary care, because that's what the original Sláinte Care said, Katrina, but it's not that. It's just free GP care. And actually all those other ancillary services, the public health nurse, the OT, the speech and language, the physio, they're just as important, or if not more important, because if you have their support, you stop people having to need the ongoing care of a doctor. Often, not always. Sometimes we need the doctors. And obviously there's this plan which called Sláinte Care, which has had, and I think continues to have, that cross-party political support. And progress is slow, but I think we're going in the right direction. And in the sort of health policy, public policy literature, there's a lot about path dependency, and it's very important the direction we're going in. And I would argue that we are going in that right direction. And that's evident in decreased charges. And again, Stephen Donnelly did a lot on that front, the abolition of hospital charges, decreasing drug charges for people on with and without medical cards. During COVID, everything was universal, free at the point of delivery. So we had a couple of months where we realized the sky didn't fall in when we did it, and it was possible. But interestingly, pretty much everything new in the HSE since COVID has been universal, free at the point of delivery. So we're beginning to get there. And access to diagnostics, which has been a real barrier for people on low income, people with medical cards, to get into the system. There's been big money thrown at the private sector to speed up their access to diagnostics, but for anyone availing of that, that's a real positive. The new public-only medical consultants contract, so this was the this was the most controversial bit of Sláinte Care, probably, was that you'd have only medical consultants working in public hospitals only doing public work. Imagine that. And there was huge resistance to that, and there was lots of reports and committees, and eventually it was introduced exactly this time 2 years ago. And right now, 60% of all medical consultants working in the public hospital system now are public-only contracts. And the sky hasn't fallen in. There's a much stronger emphasis, I think, thanks to COVID, on public health and prevention and care outside of hospitals. This effort to deliver integrated care on the front line, very much enhanced by the Enhanced Community Care Programme. And the regions, which are happening at the moment, I think are that real mechanism to make that happen and happen better. For the last 3 or 4 years, we did see this greater coherence at the top between the HSE, the Department of Health, and the last minister. And the last minister, Stephen Donnelly, really did have a focus on a political priority for universal healthcare, which really helped Sláinte Care. You mightn't have thought it was a natural home ground for him, but I think he did quite a lot. And yet that progress on universalisms and expansion of entitlements is deathly slow. You know, like even the idea like you've had, Alex, like, why can't we just roll that out a bit more? The reluctance to really make progress on it. And I think maybe we discuss what's that about. Also, this over-reliance on the market, on the private for-profit sector. Obviously, the public system needs to be built up to the capacity to do it, but in the short term, then that becomes the long term and this continuous funding of the private sector to a whole range of things. And as Roisin Shortall pointed out, talking last week, you know, perhaps it suits the status quo to maintain the system as it is. Perhaps it suits many to keep us as we are. I would argue against it, but it's worth keeping. So in conclusion, I'm at my 20 minutes. I would argue there's no perfect health system, Katrina. We can't just go, what are they doing? And let's do it here. We've loads of difficulties, but we're going in the right direction. And I think there is a general, like having read pretty much any document that's been published in the last couple of years, in the last 6 weeks, thanks to you, Katrina, there is a consensus on that direction of travel and a plan in place. And nobody really going, we got to go this, this, and this. And that's really important in healthcare. We do have a tired and weary workforce, and yet we're providing better care to more people in more services. And I think fixing the system or making the system better is absolutely key to that minding the workforce and attracting young people in and keeping the people there who are there. We know what the ingredients are for this whole system reform. And we are trying to draw on the best. And we do loads of work, Ireland does loads of work with the European Observatory to learn from across Europe and the broader European region, but also drawing on the best of Ireland and how what we're doing here can be good and scaled up. And yet I think the missing link, and it's great to see Gráinne Healy, because Gráinne began this work for Sláinte Care just before COVID, the end of 2019, early 2020, that this needs to be experienced and owned by the public and communities. And that's the missing bit of Sláinte Care. And until people see real wins in their lives and buy-in, and I think the regions are key to that, and the regions getting out of the traps are a real opportunity if we get it right. Obviously, we have a new minister. She's just in the door a few weeks. I'm really interested to hear her reaffirm the vision or tell us what is her vision about how you deliver a timely access to universal healthcare, and not one that's just fit for, because we're not going to do it by 2028, but we could, like Damien McCallion saying, we have all the building blocks we need for digital health by 2030. You could have all the building blocks you need for universal healthcare by 2030 with a view for a system that's really fit for purpose in another 25 years. Like, not wait for 25 years, but during that long view. And I'm going to leave it there. Sorry for taking a bit longer.
Thank you very much, Sarah. Actually, just on that last point, the Lancet in that piece I mentioned, which is just the recent Lancet, by the way, is the one that just came out last week, so it's hot off the press, revisits this point about the cost of, and you're quite right to make the distinction between free primary care and free GP care. GP care is just a very important component, but it's not the whole thing. And I remember at the time, we thought that the cost was somewhere in the region of $500 million. This is 10, 12 years ago. The Lancet, whatever numbers they've, or wherever the source for their numbers, say somewhere between 3 and I think they say 8 or 850 million. So that's a good deal short of $1 billion. But what you would get for that, you know, like what that could deliver, it seems to me, would be extraordinary. So the comparative. So one of the things that Sarah says is, I'm quoting this from her slide, but I'm not sure if she actually used these words in her presentation. We're doing well comparatively, not fabulously. but better. And a very fair assessment, I think. And Katrina Crowe, the curator of this series, is a historian. And I was recently reading a very interesting series of essays about Joe Lee's book. So I've taken Joe Lee's book down again, Ireland 1912, 1985. I mean, just an extraordinary piece of work and well worth revisiting. But one of the themes, of course, of Joe Lee's work is to look comparatively, and not to be looking comparatively at Britain, as we traditionally have, but to look at other comparators in Europe. Finland, I think he took an interest in. Denmark, I'm fairly sure, perhaps Austria. And there's a number of booklets in front of our next speaker about those very countries. And Dimitra Panteli is so well placed, being the programme manager, as I've mentioned, of the European Observatory on Health Systems and Policies, to go beyond what Sara's very fair assessment and to look at it, to pull back and to be able to draw on her knowledge of other comparable health systems across Europe, and to maybe give us her verdict on how well we're doing, or at least to draw on those other countries and to tell us sort of the good and the bad and the kinds of things that we might want to follow and might want to know about. Dimitra's work focuses on evidence-informed health policy and evidence-based healthcare across Europe, particularly regarding quality of care, coverage and access. She leads the Observatory's pillar of work on innovation and supports its knowledge brokering programme in evidence briefings, webinars and policy dialogues, just like this one, I suppose. So the floor is yours, Dimitra. Thank you very much for being here. Flying in with some slight mishaps earlier in the day, but the flight took off and we're delighted that you're here.
Yes, thank you very, very much, Alex. Thank you, everyone, for having me. The flight took off, but most importantly, the plane stayed active throughout the flight, so we arrived. Sara, I've known for a while. She said when she started her marvelous presentation that she got a stream of consciousness from Katrina and had to figure out how to pack that into 20 minutes. And now I have to somehow react to everything that Sara said in less time than that. So I don't know, it's hard to decide where to start, but I'll start perhaps with the European Observatory on Health Systems and Policies to explain why I am well placed to perhaps reflect on some of those issues. So the Observatory is a partnership. It's hosted by the World Health Organization, the Regional Office for Europe. But it's a partnership with almost 20 partners that includes, of course, the WHO, but also the European Commission, a range of national governments, including Ireland, then some payer institutions, academic institutions. So it's a broad range of different partners who come together because they're interested in learning from each other. So basically exactly the thing that this series tries to do, right? We've been around for 25, well, I haven't been around for 25 years with the Observatory, but the Observatory has been around for 25 years. And the idea is that it's a knowledge broker and trying to bridge what we find out in academia about what works and doesn't work in health systems with what policymakers actually decide to implement. So that's the overall idea. It doesn't always work, but we try our best. And of course, the different types of evidence that we can use are the things that Sara was talking about. So if we look at numbers, how many people are waiting, how long are they waiting? And then we see over time, does it go up, does it go down? And compare, for example, between countries to try and identify what was a successful policy that led in this particular setting to a decrease that we also want to implement in our setting. Obviously, we cannot take a measure and copy-paste it from one country to another because that's not going to work. We would need to tailor it to our setting. But that's stage two. Stage one is trying to figure out, are there any good ideas somewhere that we can borrow? So I think what I will try to do in the next few minutes is to reflect on some of the things, not all of the things, some of the things that Sara said, and bring in some of the international experience that could provide a little bit of impetus for discussion afterwards. One of my high school teachers told me once when after he spent about 10 minutes criticizing my essay in front of the entire class, gave me a really good grade. And I said, I don't get it. I didn't get any positive comments. And he said, it's easier to talk about the bad things than the good things and things like that. So I'm going to talk about the challenges rather than the great work that Ireland has done over time. It's true that the improvements are there, as Sara said. One of the things that came across very clearly for me were the waiting times. I think this is something that is for many quite a tricky thing. We saw that it's both in the outpatient setting and in the inpatient setting. It's getting better for the outpatient setting, not so much for the inpatient setting. And the first thing to say here is Ireland is not alone. A lot of countries in Europe have substantial issues. They've had them from before the COVID-19 pandemic, but the COVID-19 pandemic really exacerbated the problem. Not just because of backlogs, because for a while regular services that were not urgent were not taking place, but also because the workforce sustained real trauma and losses during the pandemic. So now we're even working in more constrained situations than we were before. So what we see in a lot of countries is that the backlogs that were created have not necessarily been deconstructed, and the waiting lists are longer. So there are different measures. Ireland already implements some of them, like maximum allowed waiting times, after which either there are penalties for providers or different options for patients, and they can exist for hospitals or they can exist for primary care. And what we see is that in particular in the Nordic countries, Finland, Denmark, a combination of implementing such a maximum waiting time that people should not exceed in waiting for a service, in combination with both supply and demand measures. So supply such as increasing, in the simplest form, hospital beds, or increasing the number of practitioners, which is easier said than done, but this is just theoretically. And also making sure that on the demand side of things, when you have a referral, it's a reasonable referral. So when there is a referral to a specialist, for example, it's for something that the patient can benefit from. The combination of these things is what works the best. Now we see differences. Denmark, for example, has been more successful in sustaining the reductions in waiting times over time. And all of these measures do complementary things. So you need to think about an arsenal and think about what will work first as a short-term measure. Perhaps you need to surge supply somewhere. We see, however, that in the increase of supply, only long-term investments actually help in the end. Like if you have surge capacity that you then take away, the effect is really minimal. So is this an easy answer? We just increase capacity different ways, contracting the private sector, opening new labs for diagnostics. It's very intuitive. It doesn't always work because sometimes you get more demand as you get more supply. So you have to work on both sides. We have recent evidence from the UK where for diagnostics, community diagnostic centers were established and a lot of investment went in there. At least for now, the effects on the waiting times are not great or are not as visible as it was hoped for. So that's with a little bit of a question mark. All of these interesting measures, they get implemented, then they need to be evaluated and obviously adapted. So on the issue of the long waiting times, working on it and tweaking along the lines of combined measures from maximum waiting times, including supply and demand, is a real piece of advice. I think Ireland is already doing several of those things. Very obviously, this rational referrals story that I talked about has also to do with low-value care. So what we talk about low-value care when we want to identify those services that are not absolutely necessary but are still prescribed or still referred for, and they don't necessarily help the patient. Sometimes, worst case scenario, they might harm the patient because they expose them to an invasive diagnostic procedure, for example. They cost the system both in terms of money and in terms of time. So one of the really interesting ways to look at this is obviously we need to make sure we have enough people on the ground, enough beds, enough labs, but are we actually sending only the people who can benefit to our capacities that we have that are already limited? And for that, we did quite an extensive work together with the European Commission. The report was just published a couple of weeks ago. Different countries have tried to implement different measures. Audit and feedback for practitioners. Choosing wisely initiative, some of you will know it. It really works on both sides, on the clinician side and the patient sides, to manage what is low-value care and expectations on the patient side. So there are these options there. But obviously on both sides, clearly the best way to reduce waiting times is to work on the side of things that makes care necessary. So invest more in primary care, catch things early before you advance to the point where you need more complicated care. So this is where we get to the point of moving to the left, investing more in primary care, thinking about what is some of the story behind the long waiting times in outpatient care, which then over time they evolve into long waiting times for inpatient care. And there I think this idea of having enough GPs or enough staff in primary care in general is really important to think about. Primary healthcare in comparison to specialized care, we know from a lot of countries, is definitely not as attractive for a number of reasons. Medical graduates don't necessarily want to become GPs or primary care doctors, so there are as well different options of how to change that. So there is change in curricula and including more primary healthcare placements. There is more thinking through the delivery model. So for example, if your standard delivery mode is single GP practices, for younger professionals that might not be as attractive. We know from Sweden, for example, they did a survey for older GPs. It was more attractive to be in single practices, but for younger GPs, it was more attractive to be in multi-professional, multi-professional clinics. So then in terms of reforming and thinking of reorganization, this needs to play into how you organize your services. One good example here is Austria. Austria has been going through a primary care reform for several years. And what they did was they went to the EU, the very first step. They went to the EU and they said, can you help us figure out how to hear from our medical students how they want to practice primary care? Let's see how that actually works well. So that was the first round of support from the EU. Then they figured out in different ways of talking that in different rounds of talking with the young potential GPs, that they needed this new organizational model with multi-professional clinics, that they needed startup funding, and that they also needed a simple guide that would tell them how to do it. Basically, how do you build up a primary care practice? So that is all provided in collaboration with the Ministry of Health and all the stakeholders in the system. Clear governance reform about wages, working conditions, and all the spectrum of the different elements that play into employment attractiveness. And then sustained policy commitment over time. I think you mentioned this as well, Sara. This consistency of trying to move into the right direction is really important. We know that for any transformation anywhere, but in healthcare is even more so. So that was a key element for success in Austria. I'll bring another example which is slightly different. It's less about boosting your workforce and more about reorganizing how you do things. And this is from the Netherlands. Goes to complexity of the system and how you can navigate a really complicated system, and how do you do that in a country that has, like Ireland, that has below average doctors but above average nurses. And the Netherlands has a really nice nurse-led example with over 850 nurse teams in the country that go and offer home care. That really has revolutionized the way that primary healthcare is being delivered, because the nurses function as connectors between the different professionals in the health system. They are responsible for their care. They are organizing the system themselves, feel empowered. And this is a really successful model that has been going on for a few years and also transferred to other countries. So this is something to think about if there is space to work in that direction. I know there are advanced roles for nurses in Ireland already, but perhaps this is a source of inspiration there as well. I think I am over my time already, probably. But maybe one last thing, yeah? Even faster than before. This whole story of moving to the left of the spectrum, obviously primary healthcare is crucial. Prevention and health promotion, even more so. So we really need to work, and this is a chain. Like if we want to reduce burden on primary care practitioners in providing actual health care and reduce waiting times, we really need to start working on getting sick less effectively, right? So on that side of things, we have really good examples from the non-usual suspects, so not from Denmark, not from Finland, not from the UK, not from Germany, but from countries like Slovenia and Lithuania, who have really tried to integrate their public health services with a primary care provision, and with a general approach that is moving different types of care or activities into the community. And we see that with everything. We see that in inpatient care, in primary care. It's less going out of the institution than into the community. And in particular, in this field of bringing together health promotion and prevention, that is working really well in those countries. I link it to an additional example from Belgium, where I live at the moment. and also to the issue of mental health, because you brought it up as well, Sara, and I think in Ireland, if our profile is correct, 1 in 5 people have a mental health condition, anxiety and depression being the highest. It's not very far away from the European average, so it's not. It's higher, but not by very much. In any case, Belgium is a good example where in the last couple of years, this idea of trying to bring mental health services closer to those who need them resulted in regional networks that try to coordinate services. And I think now with Launcher Care in the regions, that is perhaps something to think about as well. If it already exists and I'm ignorant, I apologize. But it was linked to multi-professional mobile teams that went actively into the community, that go still actively into the community, try to deliver, to first understand the need for and then deliver mental health services where they are needed. We also have recently, we did the request of the Swiss government, a policy brief on thinking about how to provide health promotion and preventive services for vulnerable children. That links quite nicely with what Sara was saying. And there we also see this need for intersectoral collaboration above everything else. So there needs to be a coherent approach that goes across education, social care, healthcare, and also tailors the outputs to the children themselves. So one really last interesting example is there, and this one is from Germany, where there is a child created or co-developed app that basically provides information about available primary care, preventive and health promotion services, and seems to be doing quite nicely in terms of uptake and effect. So I think I stop here. It was a mix of things, but we have some time still for questions, so I'm happy to go into anything that I missed.
It's some countries are doing better on some things,
Yes.
but no country is being pointed to as being the absolute, the one that we all need to emulate. I don't think.
No.
I mean, it's not. There's no reality to that ever being the case, is there?
No.
Because some countries will always be ahead on some things, but perhaps behind on other. Is that fair?
Maybe 20 years ago, people would have gone Canada or Japan or, but they didn't hold.
Yeah. That's my sense, yeah.
I think one of the most frequent questions we get as the European Observatory on Health Systems and Policies is, what is the best health system in Europe? And we always feel like, in what?
Yeah.
Like, about what is it that you want to know? Because there is not a single one. Like, there is no perfect health system. There is no silver bullet that will solve waiting times. Sorry. There's also not the best health system there.
We have about, I think, 20 minutes for discussion and questions. So I'd be delighted. Yeah, I see you in the front, Declan, and I will come to you. But I will go first of all to, if I may, just there with your hand. Yes, yourself, with glasses, if I may so describe you. Yeah.
I'm going to bring a mic down.
Yeah, we get a microphone because we're recording. Oh, great.
It's being recorded, which is why we've got to speak into mics.
Yeah.
Thanks very much. So I'm Sara Barry from RCSI, but late of the parish with Sara, working together for many years. Thanks very much for fantastic presentations. Sara, your talk reminded me of a famous line from Educating Rita, that film, if anyone remembers it, where there's a discussion, actually in Trinity College, Dublin, apparently, of what is tragedy, and the lecturer says very eruditely, well, a falling tree isn't a tragedy, and Rita remarks, it is for the poor sod under the tree. So I suppose my remark really is around that challenge of how do we get a population who are living a certain reality to actually take the long view. And to some degree, it's actually a question, indeed, drawing on your political nous, Alex, as well, and Dimitra. So just, how do we help the public understand, given the complexity, and take the long view and believe in where we're going?
I'm going to take 2 or 3 together because I see a number of hands. So just behind you, and then I'll come to Declan here close to the front. Yes, the one just at the back. Can you is the microphone there? Yeah, over there. Thank you very much.
Hi there. I'm Min Alican. I'm currently with the HSE, but more recently came from Canada. My question is a bit different. So, Dimitra, was delighted to hear about you mentioning choosing wisely, because when I was in Canada, I actually, when working in government there, provided seed funding for the Choosing Wisely Canada campaign. I was curious coming over to Ireland, though, given that it's now gone over the past 10 years to over 20 countries and like over 90, professional clinical societies involved. Why it, and maybe this is more for Sara and Alex perhaps as well, why it doesn't seem to have taken here yet in Ireland. And I wondered whether it has something to do with, the kind of the maturity, if you will, or where we are in terms of more integrated clinical and operational governance, which I see as a bit of a gap, just, observationally, but just that's a question as well, especially given the productivity agenda that's on everyone's minds these days. Thanks.
One more at the front up here, and then we'll go to our two distinguished speakers. Just here. Yeah.
Thank you. It's been a very fascinating evening. Declan Mina, Advocacy Officer Fighting Blindness. And first, very easy question. What has the HSE asked the European Health Observatory recently? And are we making good use of the facility? Because it sounds like a good facility to have. I live with a rare disease. I have 5% vision that could go at any time. And not for my gene, but for another gene, we just had a miracle cure which waited 1,500 days for the HSE to decide whether to pay for it or not. This restored sight, which previously was unrestorable. Also, I'm working on a patient submission to the National Centre for Pharmacoeconomics for an age-related macular degeneration drug, which could reduce the number of injections that people have to get. And I'd say we'll be waiting a year on that. So my question is, what's happening around Europe around the poor performance on drug reimbursement? And is there moves for a single payer for some of these more expensive drugs? Because at the end of the day, what's more valuable than our health? And I think we're going to have to open the pocketbook a bit for that. But I think it's a worthwhile investment, because otherwise people's sight will go or people will die while there are treatments that other countries have access to. And as Europeans, we don't, which I don't think is acceptable. Thank you.
Thanks very much, Declan. Sarah, take 1, 2, or 3 of those as you choose. That's always the nice thing about having grouping questions, that the responders can take the ones they like. But if you can address each of them.
I'll maybe take 2, and I'll leave Declan's maybe because I think it's directed at Dimi. Sarah, I don't know the right answer to your question, but I definitely think it's a question that'd be great if more and more of us had more of the time. And obviously, it's the same issue with the climate crisis. It's the same issue with public health. It's very hard to get people to see things that aren't quite there yet and aren't quite a problem. And if you're effective in reducing them, then they don't actually materialize. But it's only when the house floods or goes on fire or something critical happens to your health, you get it, right? So it's an age-old problem. But I do think the missing component, like if you look back on Sloan Care, was very much, it was a politically driven initiative. It was top down. It was a Oireachtas. That was the nature of it. And that's been part of its success, but I think of its making. But I think if it's to succeed in its implementation, then it can only succeed from the bottom up. And that's why I think that work with communities, with grassroots, like all of our successful social change in Ireland has happened from engaging with communities. And I do think the sort of work that Gráinne Healy began to do in 2019, 2020, that needs to happen at a regional level. And I think you can actually get a lot of people on board. Like the HSE, the health system, like even voluntary providers, they're huge employers in our community. Most people need them for their child or their parent or their sibling with a disability. I think you can get, like we saw that working with the Oireachtas committee, of very different political colours and creeds, from the hard left to pretty, centre right. They could agree on pretty much 85% of it. Most people believe every child deserves the best chance in life. No one should die in an awful public hospital ward. You could get consensus still Not sure how long that'll last. But I think it needs that bottom-up approach. And then just briefly, Min, on low-value care and choosing wisely, I can just see it's beginning to happen. I have colleagues there's a couple of Sphere PhD students who are doing work around low-value care, a couple of clinicians, academic clinicians beginning.
I don't know what low-value care is.
Okay, so I'm not sure I know the correct definition of it either, but how I understand it is that we've been doing loads of things in the health system forever, that the evidence base maybe has changed first. So we've prescribed for something that actually doesn't help you with that treatment, or you refer them for a treatment that isn't effective. And therefore we need to get rid of stuff. We can't just keep on adding more and more on, and sometimes that stuff is quite expensive and sometimes it's quite ineffective. And so we need to be not just adding more and more care in, but getting rid of the low value care. Maybe you'll give a better definition.
No, as an example, like for example, if you get sent for an MRI for low back pain, where there are no red flags that there might be something really serious going on, chances are you won't get any knowledge. But
you don't need the MRI. We actually began to do a bit of it during austerity. We began to take stuff off the drug payment list, and people were up in arms. Joe Duffy was up in arms about all those nutrient supplements that do nothing for you being taken off the free list. So they're hard to do, I think, is the experience as well. So I'll leave it there.
I think I'll start with the last one. I think a lot of the way that the observatory works, our partners come to us with questions. That's part of it, but also they are really engaged in ensuring that the results, if we are asked to find good practice about a certain area, are also a public good and are published. The specific requests from HSC, at least as far as I've been there, I know that there was inputs into Slonček care itself, so I don't know what they were because I wasn't around at the time. There's a report that was published last year about sustainability of home care and the link to population trends. We are now working on a number of issues, including affordability and out-of-pocket costs, the role of the private sector. I don't think I can talk about more in detail about what they are because also we don't know the outcomes yet. But I think we are really happy with the way that the outputs that we prepare are then taken into account. So I think that's something that I can definitely say. Sure. On the orphan medicines, I think that's a really important point. I think I did in my previous life when I was at university a lot of research on health technology assessment, and when we were talking about orphan medicines or medicines for rare diseases, it was really always the toughest question because they're usually really expensive, and different countries have different ability and willingness to pay for treatment, so we could see really clear differences between the share of newly approved medicines that were reimbursed in different countries. I think based on the last numbers that I have in mind, Ireland was somewhere in the middle of the spectrum of European countries. My hope is we now have the Health Technology Assessment Regulation, which is a new law that basically says that all European countries, EU countries, together assess the clinical value of new medicines. So they say, do they work better than alternatives? And therefore, should we be paying for them out of public funds? It still doesn't say, obviously, because the EU is not allowed to do that, what individual countries will pay and will not pay for. But my hope is that this joint assessment of the evidence is a first step for then saying, if we don't do joint procurement for orphan medicines, what are we going to do it for? Like working together to buy means creating economies of scale, and when these are rare instances, that's the point where you have to intervene. We also saw yesterday, last point, the draft for the Critical Medicines Act, which is a new vehicle to ensure that the supply of medicines, or that the supply of medicines is adequate, because we've seen the issue of shortages in the past few years quite radically, but also that all patients in the EU have access to the necessary medicines. Part of it, I haven't read the whole text, part of it really is about what the options are for joint procurement. So my hope is that there is indeed progress there. When and how it materializes, we still need to see.